Wonderful. So this is the hypertension for the T2 cohort, and this will be led by our lovely doctors Danya, Sandeep, and Jyoti, and the pharmacist Manpreet Saini. Please take it away.
Hi, everybody. I'm Dr. Shoaib. I am one of the Redbridge GPs and the Fairlaw PCN educational leads. I've got my lovely team here, which I'll pass over to introduce themselves.
Hi, I'm Dr. Singh. I'm one of the GP registrars.
Hi, I'm Manpreet Saini. I'm one of the practice pharmacists.
And I've got my lovely colleague, Dr. Jyoti. I'll just pass over to him.
Hello, thank you. No, I'm Jyoti. Although I work part-time in Redbridge as a GP, and I'm the Havering South PCN clinical education lead. Thank you for joining us.
Wonderful. Are we ready to share? Shall I share the PowerPoint?
Thank you. Thank you, everybody, for joining us today for our hypertension, for our Tier 2 hypertension talk. I'm going to get Dr. Singh to start off.
Hi, everyone. So it's great to do this session. We've done quite a few LTC sessions that have been quite good. Today we're tackling hypertension for the Tier 2 cohort. So we'll go a bit more into the management than we have in the previous course. So when we did this, it's just a brief introduction of what blood pressure is. It's an imbalance of normal physiological responses. So your body is constantly responding to volume overload, high stresses, narrow vessels, and is adapting for them constantly. And it's when this imbalance has become imperfect that we then start to have a state when we have high pressure of fluid throughout our blood vessels. And that's essentially what blood pressure is, with multiple factors involving genetics, lifestyle changes, and pre-existing conditions. Next slide, please. If you click along. Perfect. And again, excellent. So essentially, this was just a diagram signifying the importance of hypertension and what happens if you have an increased amount of pressure that's happening throughout your blood vessels. Everything starts compensating. So if we start breaking it down, we think about the nervous system involvement, our heart involvement, and our kidneys involvement. So we've got lots of receptors that deal with overload. When you have a lot of stretching happening, you're going to have firing of receptors to try to lower our blood pressure. You're going to have your heart stretching to release natural diuretic hormones that's going to try and diurese your body to reduce volume overload. If you've got narrowed vessels, you see the heart compensating by getting into a hypertrophied state to try and push out the blood throughout those narrow blood vessels. And it can happen with valves as well. Then you've got kidneys, which help very well in having good chemoreceptors, not just to sodium, but also to volume. Very active in the macula densa to regulate blood pressure. So when all of these things stop working, you start to get, the common chronic conditions developing, like heart failure due to hypertensive heart disease. Someone that's been stressing their heart throughout can develop a hypertrophic state. When the muscles stretch beyond that sarcomere region, they become to a state where you get heart failure. Next slide, please. And perfect. And one more click, please. So these essentially are the main complications that we look at, and they are actually the main parameters and organ damage. If you've got really severe blood pressure happening for a long amount of time that's uncontrolled, these are the complications you get, because these are the elements that try to balance it out. We've already spoken about the heart becoming hypertrophic and failing. We've spoken about the kidneys as well. If you have changes in your renal perfusion, it gets to a point where you can develop AKI and then CKD, and that's due to renal hyperperfusion or renal hypertension, thereby affecting filtration systems, causing protein leaks, and leading to a number of complications in that domain. Then you've got the two other hallmarks, which we commonly use when someone comes in with malignant or concerning hypertension. It's stroke and also changes in vision. The one on the eye shows a fundoscopy with lots of common changes that you get, cotton ball spots that can happen in the eye, hard exudates. I know that not all of us do ophthalmoscopy, so commonly it gets picked up when they go to the opticians. The ones that we need to be very concerned about is the fact that they are high risk of having stroke. Hence the uprising of wanting to do Q risk, or that's now come up to Q risk 3, looking at lifetime risk. Next slide, please. I'll hand over to Manpreet now, Ms. Sani, to cover management of hypertension.
Hi everyone. Right, so as Dr. Singh's just spoken about this, blood pressure, it's not just simply a case of somebody's got high blood pressure, it needs to be managed, and it needs to be, management is very important because of the aforementioned complications that you can get. It's not just about the heart, but it's also things about the kidneys, your eyes as well, and probably something which doesn't get emphasized too much to our patients. So first of all, we need to think about what should the blood pressures be if they are high, what should our targets be? So if we just go to the next slide. So now, one thing you need to understand is blood pressure targets do vary. They vary according to age. They vary according to comorbidities as well. So as you can see on the screen, for patients aged 80 or less than 80 years of age, usually it shouldn't be more than 140 over 90 millimeters of mercury. And that's even if that's even if the patient has diabetes, it should be less than 140 over 90. However, if the urinary ACR, that's the urinary albumin creatinine ratio, is 70 or more, then we need to be a bit more tighter. Then usually we tend to aim for less than 130 over 80. Same goes for retinopathy as well. If the patient starts showing signs and symptoms of retinopathy or maculopathy, once again it should be no less. Needs to be less than 130 over 80. That's just the maximum. For our older patients, we get it's a bit more looser, I suppose we could say, and it should be less than 150 over 90, and that's irrespective of the urinary ACR and if they have diabetes or not. Generally, diabetes tends to trump all of those things, just to let you know. And we've just got a reference there at the bottom about the National Stroke Guidelines, where if somebody has a mini stroke, a TIA or a stroke, then the systolic should be less than 135, and the home systolic BP should be at least less than 125. Can I have the next slide, please? Okay, so it's graded in different stages. Now, usually, if the ambulatory, the 24-hour blood pressure monitoring, or your home blood pressure monitoring, if the average is between 135 to 149 systolic over 85 to 94 diastolic. If the patient is less than 80 years of age, good idea is always to work out something like your Q risk 2, or as Dr. Singh earlier pointed out, Q risk 3. If it's less than 10% and the patient is less than 60 years of age, consider pharmacological treatment, which I'm going to talk about slightly later. If they're 60 years of age or more, then start advising with regards to lifestyle as well. However, if it's 10% or more, we need to think about pharmacological intervention. If you have patients who are less than 80 years of age and they have cardiovascular risks, if they've got a chronic kidney disease, diabetes, as I said, is a thing which tends to trump all, or any target organ damage. So we're talking about the kidneys and the eyes here as well, and the heart. Then again, we need to think about treatment. If you have patients who are 80 years or more and their blood pressure is over 150 over 90, again, we need to think about pharmacological intervention, something that a lot of our patients, let's face it, they're quite resistant to that. But a bit of patient education does go a longer way. Can you have the next slide, please? Okay, so stage 2 hypertension management is if the 24-hour readings or the home readings are in excess of 150 over 95. Now, the European Society of Cardiology and the ESH recommends to start pharmacological intervention for grade 2 or grade 3 hypertension. We'll talk about grade 3 in a second, and that is regardless of what your level of risk is. But however, you do have to look at the patient in a holistic manner. If you've got a patient who's particularly frail with it, lots of multi-morbidity and things like that, you need to take those things into account as well, and any comorbidities as well. So they have to be right for whatever pharmacological intervention you are about to make. And obviously thinking about, whether they have diabetes, obviously you'd be thinking about if they had diabetes, you might need to think about things like ACE inhibitors or your ARBs. If they've got other cardiovascular problems, CKD, again, you might need to think about ACEs or ARBs, or even your calcium channel blockers. Usually, if somebody is showing, for example, a high urinary ACR, you want to think about your renal protection, as we call it. So once again, you might think of ACEs and ARBs. Next slide, please. Okay, right. So for step one treatment, okay, so if the patient is less than 55 years of age, offer them the ACE or the ARB. However, there is a bit of a caveat to that. Patients of Black African or Afro-Caribbean ethnicity, you would offer them a calcium channel blockers, so your amlodipines, lisidipines, felodipines, so on and so forth. Usually that's because the Afro-Caribbean patients tend to show that there's a higher risk of them getting things like angioedema for your ACE inhibitors. If your patients are less than 55 years of age and of Afro-Caribbean ethnicity, and they have diabetes. Now, if you remember earlier, I said diabetes tends to trump everything. So if they do have things like diabetes, you need to think of offering them an ARB. But as I said, ACE inhibitor is probably not a good idea, but offer them the ARB at least. And any patients over 55 years of age, you offer them your calcium channel blockers. And if obviously for any patient who's on the ACE inhibitor, we all know dry cough is a major issue. So if they're suffering from dry cough, then you can offer them an ARB as well. Usually it's a good idea to actually counsel the patients about things like that beforehand. Sorry, next slide. Okay, so going forward, if a patient has if you would offer an ACE or an ARB, or even a thiazide-like diuretics if the patient has already been started on a calcium channel blocker. However, you would offer a calcium channel blocker or a thiazide-like diuretic if they have already been started on an ACE or an ARB. So when we think of thiazide-like diuretics, really we're talking about our indapamide here. You would offer an ARB, and as I mentioned, an ARB instead of an ACE inhibitor for the Black Afro-Caribbean patients. Because of the risks of angioedema. And obviously, when you are going to escalate your treatment, always do make sure that the patient is concordant with the medication as well. Next slide. Okay, moving on. I grouped step 3 and step 4 because at this point, quite frankly, it becomes serious. So, quite frankly, if it's a case of the patient has progressed into step 3 and step 4, we're thinking triple therapy. So that's your ACE and ARBs, that's your calcium channel blockers, and that is your thiazide-like diuretics. However, if despite triple therapy, things are still not working, then it's a case of, well, why is it that this patient has what we call refractory hypertension? Is there any postural hypertension or anything like that? Or is it just a case of non-adherence? So something things we need to consider. The next step on from that, and certainly things that I've certainly had to use, is we take a look. Obviously, you do get your blood pressures done. If they are on your ACE and ARBs, you do need to make sure that the kidneys are coping well with them. So with your U's, what should come up is your potassium. Take a look at the potassium. If the potassium is no more than 4.5 millimoles per liter, add a low dose spironolactone, usually 25 milligrams just to begin with. And obviously, you need to keep an eye out on the potassium because that is a potassium-sparing diuretic. If the potassium is more than 4.5, then think about your alpha blockers or your beta blockers. Beta blockers don't get used so much, but however, I've certainly noticed with the older communities, we do tend to have quite a bit of atenolol because once upon a time it was the rage. But things such as doxazosin for your alpha blockers and things like atenolol for your beta blockers. Next slide, please. Okay, so hypertension in pregnancy. So usually you tend to have complications with blood pressure in pregnancies if the pregnancy is happening at an older age, usually above the 40 years mark, or if the patient happens to be obese. So good idea, first and foremost, is refer to OBS and gynae. Usually the patient will be under them as it is anyhow. They may require, a lot of this comes from OBS and gynae, by the way, but they very likely will require 75 to 150 milligrams daily of aspirin. Sorry, aspirin's missing there on the screen. And usually that's taken from weeks 12 till the time that the child is born. You need to offer lifestyle advice. Lifestyle advice really is across the board anyway. Weight management, obviously, for them to have exercise as well. Usually for pregnancy, that's something which will be they'd be advised on by the antenatal clinics as well. A healthy diet. Now, anybody who's sat with me, my catchphrase tends to be less sugar, less salt, less fat, more fiber, and smaller portions. And as I've just mentioned, there's salt reduction as well. You may need to refer for a specialist assessment as well. And obviously they can check for anything further, any risks that they need to manage going forward. If the blood pressure does rise above 160 over 100, they may well need to be admitted into a hospital as well, and the case may need to be managed there as well. But otherwise, we would offer antihypertensive treatments if the blood pressure is between 140 over 90 to 159 over 109. Next slide, please. Okay, so one of the things we need to think about is that ACE and ARBs are very likely to increase the risk of congenital abnormalities. So ACE and ARBs is a no-no if the patient's pregnant. Usually, I believe I read somewhere that if the patient happens to be on them and they find that they are pregnant, within 2 days, ACE and ARBs must stop. Thiazide or thiazide-like diuretics as well do increase that risk as well, and neonatal complications as well. So that's something else that cannot be used. Now, because there's limited evidence, because a lot of trials aren't done with women who are childbearing, there's not a lot of information. The information is quite scanty out there, quite anecdotal. So the typical ones we tend to see if the blood pressure is over 140 over 90, because the target is we need to get them less than 135 over 85. So usually first line tends to be labetalol. We do tend to see a lot of labetalol. Second line usually ends up being nifedipine. I think only on one occasion did I see something like amlodipine as well, but usually it is nifedipine. And third line, not seen so much, maybe just seen a few of these, is methyl dopa as well. And if it's safe for the patient, you would continue the treatment. Usually, my understanding is that the treatment will, after birth, the treatment may well need to continue for the same duration of that the patient was on it whilst they happened to be pregnant as well. If the blood pressure is less than 110 over 70, think about whether if they are symptomatic with hypertension, you would probably need to think of changing the treatment as well. Next slide, please. Okay, postnatal management, as I've just touched on, if the blood pressure falls less than 130 over 80, we can reduce the antihypertensives eventually to stop. Okay, if the duration of antihypertensive use is often, like, as I said, the duration of antihypertensive after the baby's born usually goes on for the same amount of time that it was used in pregnancy, as I mentioned. You would stop methyl dopa and switch that treatment within 2 days of delivery as well. Why? Because methyl dopa can be linked to postnatal depression. And if the patient has a history of preeclampsia, ideally they should be under hospital management until the blood pressure is controlled, and as long as the blood tests come back normal. Next slide, please. Okay, antihypertensives. Most drugs, including antihypertensive, some part of it will transfer into breast milk. So therefore, signs of hypotension in the neonate would be things like pallor. The neonate will be pale, poor feeding, coldness of the peripheries is quite key as well, and lethargy. There might be others as well. Usually, postnatally, enalapril is usually used for things like that, and they will need blood pressure monitoring after that as well. For the Black Afro-Caribbean patients, you may need to consider nifedipine for the reason that I mentioned beforehand, or amlodipine as well. So we just skipped ahead. And once again, avoid diuretics, avoid your ARBs if they are breastfeeding, or if they're ACE and ARBs if they're expressing or they are breastfeeding. and obviously do follow, keep the NICE guidelines close at hand. Next slide, please. Okay, so just a bit of information about the different drug groups that I've mentioned, your ACEs and your ARBs, okay? Your ACEs, when you think of ACEs and ARBs, think kidneys, okay? So do check their U's and E's before starting, and once you've started it, after 1 or 2 weeks, ask them to have another blood test again to check their U's and E's, and you need to check that each time you increase the dose as well. And also you do need to, it can raise your potassium levels as well. So potassium hyperkalemia, we need to watch out for that as well. The typical side effects, as I've already mentioned, are your dry coughs. Other things would be things like dizziness or headaches. Angioedema, I've already mentioned, might be a good idea for the patients to take their first doses at night as well. But of course, contraindicated in pregnant women and those who are breastfeeding. Next slide, please. Your thiazide-like diuretics as well. Now, they should be avoided in refractory hypokalemia because obviously they can worsen it, hyponatremia for the same reason, and hypercalcemia. They should be avoided in Addison's disease and symptomatic hyperuricemia as well, because they can raise your uric acid levels as well. If there's severe liver damage or there's severe kidney damage, and the creatinine clearance is less than 30 mils a minute, a good idea not to use your thiazide diuretics. They're not usually effective if the kidney function is less than 30 mils per minute, and obviously not for pregnant women either, for the reasons already mentioned. Do monitor your sodium levels before you start treatment and then at regular intervals. I've already mentioned about your potassium levels as well. Continue to check the kidney function whilst you are on your indapamides, and also do check your liver function as well. Next slide, please. Okay, your calcium channel blockers, typically your amlodipines. Your calcium channel blockers, they can precipitate heart failure as well. So usually they're not to be used with, certainly with caution in patients with heart failure. They shouldn't be used in patients with heart failure with a reduced ejection fraction, or those with impaired left ventricular function as well. Even if it is controlling their blood pressure, that's usually a no-no. Things like verapamil and diltiazem shouldn't be used in patients with left ventricular failure either. For patients with uncontrolled heart failure, again, avoid. Amlodipine has been used, but you need to be quite cautious with regards to that. Again, the typical ADRs, your side effects are things like peripheral edema. I'm going to mention that first. That's usually the first things. Dentists hate amlodipine because it can cause gingival hyperplasia. So the amount of patients that come back to me telling me that their dentist has told them they shouldn't be on it. So that's something to think about as well. Palpitations is another one, and your nausea, vomiting as well. Next slide, please. Okay, now this slide just basically shows the fact that you've got a lot of combination ones. You've got a lot of combination type ones which can be used as well. Usually, this is quite useful in patients who happen to be on a lot of drugs. And we're talking about, say, your elderly patients as well, patients who have memory problems, patients who may be on using blister packs or Dorset boxes or things like that. It reduces pill burdens, okay? I mean, they are quite expensive, but if it's helping the patient, then obviously you put your patient first as well. So that's quite an extensive list there that I've got that we've got in front of us, and some which we are a bit more familiar with than others. So obviously, if you do want to try to reduce your pill burden, please think about these combinations as well. Next slide, please. And lifestyle management, as I mentioned as well. So weight reduction it is actually important. People don't think about this too much, but it can lower your systolic by a good from 5 to 20 millimeters of mercury. So weight reduction always helps, and obviously you would do that with your diet and your exercise as well. Salt restriction as well. Too much of the sodium, obviously that's not going to help your hypertension. Smoking management as well. Usually I have one of the things which is highly recommended is you ask, you advise, and you act. ask your patients, I mean, use each patient contact as an opportunity. Ask them if they do smoke, how much do they smoke, what is their smoking history, advise them, because it's not just usually things like the lung cancer, which obviously won't help either, but it's also the cardiovascular risks as well. I educate your patients, if needs be, give them a brief biology lesson if you have to, but often I find that by explaining these things to them, the patient connects a bit more with their body and therefore is able to understand and take away whatever the information that you're giving to them, and refer for smoking cessation as well if needs be. Management of obstructive sleep apnea is an important one as well. Exercise we've already mentioned, and things like that can actually account for a 15% reduction in all cardiovascular events. Next slide, please.
Cool.
Okay, and these are just a few references for some key trials you might be interested in. Thank you.
Right. Okay. So I'll just go over these few trials. So that was a nice outline of what blood pressure control is, what the targets are required, and actually European Society of Cardiology have actually suggested increasing, actually starting off patients with dual antihypertensive in the start, but that's not yet employed by NICE because they obviously were worried about, hypertensive induced ischemia that can happen by just reducing it rapidly. So I'm just going to go through a few trials. Yasmin, if you just click along. Okay, so essentially these are like the startup trials that happen. So in the beginning, they got a group of elderly patients and they tested to see whether reducing the blood pressure would be effective. And they noticed that there was a reduction mainly in stroke risk, but also some other major adverse cardiovascular events. They then went on to actually find out what level would be very good, and they found around 140/90. And they looked mainly at this study using diastolic blood pressures. They after doing that, they wanted to find a bit more about which medicine would be just as good or what would be the optimal medication. They found that diazides at this time were just as good as the other medications. So at the time, they were using beta blockers, ACE inhibitors, and also calcium channel blockers, and they found diazides just as effective. That trial was a non-inferiority trial. If you go next. Yep, brilliant. So these next set of trials, what they were looking at was what combination would be great. And they found that patients that were on amlodipine and ACE inhibitors were actually doing the best. And they compared it to another arm where they had a beta blocker and a thiazide. And they found a marked reduction of stroke. And I think I've written the percentage on this one, 23%. So moving on from that, then they wanted to find out should we be achieving an even better target? And two trials, there's a bit of conflict in between them, but they did show that really low targets of around 120 were achieving good events. One of them found that there was no significant reduction. The other study showed that actually we've reduced quite a lot of major adverse cardiovascular events. But both of these studies ultimately did state that the adverse risk of having low blood pressure was even higher because you have patients that are going to have high postural drops. You're going to have elderly patients that are not tolerating a lower blood pressure and are going to have risk of falls. The first study where they did it on, the sprint trial where they did it on, they used a younger cohort, so they didn't actually see much of these adverse effects, whereas in the ACCORD trial, they did see that. And so NICE hasn't adopted to using this very low 120 target across the board. So next, please. So this is a really interesting study. So you've got a trial here that actually showed that it's irrespective of whether you've got cardiovascular disease. If you've got high blood pressure, it is important to reduce it because you've got a reduction of 10% in your cardiovascular events. And that's whether or not you've got raised lipids, whether or not you've previously had a history of angina, or got ischemic heart disease. It doesn't matter. If you've got raised blood pressure and you reduce your systolic pressure by 5, you're actually benefiting yourself to avoid a heart attack or stroke happening. Now, the other two studies that are here, the interest for these are time of medication. We often sometimes think our patients are taking too many hypertensives in the morning. Let's put some in the morning, let's put some in the evening. And sometimes we're not sure. We're worried, should we be giving them a blood pressure at night when something happened? Well, it's not really going to show much because the studies that we have, one of them suggests that actually you're actually causing a significant reduction in major events if you give them medication at night. the other arm is actually showing that if you give elderly patients lots of blood pressure medication at night, they have to get up to go to the toilet, which most elderly patients do when they start developing nocturia. They are at risk at that point of having a postural drop or having a hypertensive episode and leading to a fall, fractured femur, having to go to hospital. So that's the complications that can happen. So it's really about weighing it. In my practice, I do often use blood pressures in the evening, but at a lower dose compared to what I use in the morning. And I do it just to spread medication out. And sometimes I do give one in the morning, one in noon, and one in the evening. Next slide, please. So if you click along. So we all know if someone's got a really high blood pressure and they come into clinic, we get really concerned. It's something like 180 or above systolic. Sometimes we don't even look at the diastolic. We're just worried 180 is really high. So if a patient's got chronic hypertension, there's no need to actually get alarmed at that point. It doesn't mean they're going to walk out the clinic room and have a heart attack or stroke. It means they need to have treatment done. You don't need to wait about checking again in a week or 2 weeks. Whether or not it's white coat syndrome is not something you can determine in the clinic. So give them a prescription, because if they do have white coat syndrome, most likely it'll be 140 or 120. And if they do develop symptoms of dizziness when they're at home because their blood pressure is normal, tell them to stop the medication and safety net them for hypertension. So essentially, patients that get raised blood pressure like this, give them medication to control it. There are offsets where you do want them to go to A&E if they're confused, if they've got any visual issues, if they're telling you that they've had changes in the urine output, or if they've come in saying, actually, I've got an ache in my chest, it's really hurting over here. You don't want to just take that lightly and be like, okay, fine, you've got issues happening that could be a concerning malignant hypertension. You need to go to a hospital. One sign that's not commonly seen is that patients sometimes come in just sweating. They have no symptoms, high blood pressure, they're sweating. You don't know what's going on. Send them to A&E. And the last thing to note is that it's not often done because we see a really high blood pressure. But if you see a marked postural drop in someone that's got a blood pressure of 180, they need to be seen urgently. It means that the autonomic nervous system is being affected, hence meaning that they've got reduced cerebral perfusion. Next, please. So referring to, if you go back, so referring to secondary care. So you've done as best as you can. You've got them on 3 medications. It's not working. You're not sure whether you want to add a 4th one, if it's going to make any benefit, or you're just going to increase pill burden and side effect dynamics. So you can then decide, I'm going to refer them to hypertension clinic. We're not getting anywhere with this. Make sure that you do all the necessary investigations, doing an echocardiogram, an ECG, looking to see whether the renal function is declining. Is it due to a renal stenosis that's happening? Have a look to see whether they've got proteinuria. These are very key markers that we can tackle to actually help with controlling blood pressure. If they're less than 40, new onset of hypertension, look for end organ damage. If you find a cause, great, but have a low threshold of considering referring them if you need to. But normally in less than 40, I don't refer. I just investigate with echo, ECGs, and renal ultrasound if I need to. Next, please. So resistant hypertension, essentially you reach the limit of the most common 3 medications that we use: calcium channel blockers, thiazides, and also ACE inhibitors or ARBs. The next step is either using an alpha beta blocker, which we all will comfortably do, and sometimes spironolactone, which commonly in certain areas requires a shared care practice due to monitoring, mainly when it's initiated for heart failure. You can start spironolactone if the potassium is less than 4.5. If it's more than that, then have a low threshold without hypertensive involvement, because you should get a shared care agreement, because it does need monitoring. And most of the time, it's not wrong after triple therapy or quadruple therapy just to refer them straight for hypertension clinic. Hypertension clinic's there to either give them a direct renin inhibitor, which is called eliscarin, or whether they want to consider at this stage doing renal denervation through ultrasound guidance, where they denerve the sympathetic input to the renal system, and that sort of inhibits the feedback, causing you to have vasoconstriction through the renin-angiotensin system, but also through direct sympathetic drive. Next, please. All right, next. Okay, I'll hand over to Dr. Shoa.
So, how do we monitor blood pressure, and what do we do? What is it that prompts us to monitor? We're all in the cough season, and we're looking for optimal blood pressure control. If you've got a blood pressure control according to guidelines less than 120/80, again, repeat 5 years. If it's slightly above, then 3 years. But if it's high to normal blood pressure and you think it might be have an element of being masked, repeat it at least every year and consider just signposting them to doing home blood pressure monitoring. Now, if the blood pressure constantly remains high, then either repeat clinic blood pressures or ambulatory blood pressure or home blood pressure monitoring. Ask them to Accurex their readings if they're doing it at home, and then decide on management options. Next slide, please. Yeah, thank you. So these are just the what's available out there, what we can do, the normal guidelines and the resources that are present, what programs can we do, and what resources we can signpost our patients to. Next slide. Now this is really, really important. Blood pressure control is basically teamwork. How do we get the patients achieve the best possible outcomes? We've now are lucky enough to have our social prescribers, our care coordinators who are working with us. It's not just the pill that works. It's actually the wider support that people get. People can have normal problems. They wouldn't have housing problems. They might be isolated. They might need more support. They might have additional needs. They might be having learning disabilities. They're vulnerable. That's where our care coordinators, my health and well-being coach, who will encourage changes in behavior. How do we encourage this change in behavior? By providing support. It's very easy to give medication, but medication on its own will not help unless other measures are put in place. So that's where we use our whole team to help tackle hypertension. Next slide, please. So my lovely colleague, G, who's not here with us today, she's our senior health and well-being coach, and she's put this lovely slide together who gives us the MDT approach, where what matters, what's the importance of personalized care, the importance of health and well-being coach. How do we get care coordinators to reach out to those people who we know that need at least an annual check? They're vulnerable. How do we get to reach out to them? How do we get our social prescribers linking in with the people who might be at risk of neglect, who might have long-term needs and things? How do we get them involved? So this is a slide basically showing how we use a multidisciplinary team approach to actually link in our patients, to actually get them to educate themselves, introduce behavior change, and actually then work together with the clinicians in improving their quality of life. Next slide, please. Again, role. Lots of people don't understand, lots of our patients don't understand the role of health and well-being coach. What are social prescribers? Who are care coordinators? What is the conversation that helps transform what matters to you? What is the matter with you to what matters to you? But then again, it's our role as clinicians to educate our patients that, yeah, but they're not doctors. But yes, you don't need a doctor. The doctors have given you the medication, but what is it that despite having the medication is not working for you? What do you need that will help improve the quality of your life, which will in turn just help the medication to work better? So it's our job essentially to actually help patients understand the personalized care roles that are present within our team. Next slide, please. So how have you accessed the personalized care role? The referral process, again, it's quite easy. We select the social prescribing and look at the inbound referrals and then look at it's different processes, different places. In some boroughs, they've got the Joy app. where you use it, but for some, we will email and the social prescribing team, who are very good, and get back to us and let us and contact our patients. So everyone works differently. As long as we're working towards the same goal, that should be okay. Next slide, please. Again, very important to work together as a team. We are a team. No longer are we working in isolation. We work together. We find out what's happening. We do the whole holistic care approach. Look at everything that works in patients' well-being. Next slide, please. Again, G has put together this lovely slide, which has just having, sometimes you need to talk to somebody, which, you know, a doctor, one of us, me, Dr. Singh, Dr. Jyoti, we won't have time to basically explore everything in 10 minutes. But then we can actually signpost them to an excellent service who we do have, which our care coordinators are present. They can help coordinate care plans, have somebody verbalize your thoughts, and look into what are the other services available. That will help. Next slide, please. So I'll pass over to Dr. Jyoti, who will talk to you about case studies. Thank you, Dr. Jyoti.
Thank you. I'm going to talk about couple of case studies, so that these are the cases we commonly come across in our practice. Next slide, please. Yes, like as Dr. Soeb was talking about the ARR staff, the primary care is not just about the GPs and the nurses and the pharmacists. Now, we have lots of other ARR staff. They do have a role. They have a role to play as well, because they do come across patients with high blood pressure. So they also have a role to play. But that's why these sessions are quite helpful for them to understand and to manage in their roles, not necessarily medically, but also otherwise. Thank you. Next slide, please. So this is Peter. It's again the common scenario you come across. It's a 50-year-old gentleman. He's an insurance broker. He came for a routine check. I'm sorry, I don't have time. Doctor, I have only 10 minutes. I don't have any time. So he came for a health check, and the healthcare assistant noticed these points. The smoker, alcohol, father had a history of heart attack at age 55, and he is working long hours, no time for exercise. It's a common situation, don't they? Because people are very, very busy. In the middle age, they have lots of money, but there's no time for themselves. Next slide, please. So this is the clinical examination. So pulse is okay, slightly high, but the blood pressure is high, BMI is high. So what would you do next? So here, we can bring this ARR stuff. What investigations would you do? And what medical management we talk about. So next slide, please. I think as per the previous speakers, the lifestyle advice through our health and well-being coaches or social prescribers, they can all have a role to play. Diet, salt, weight reduction. There are tiered weight reduction services. We have this tier 1 to 4. Exercise, gym, walking tours. It is amazing. The local authority, they do have walking tours. If we can signpost them, some of them are quite. They want to join these kind of walking tours. They develop friendship and they enjoy them. This is my experience when I was in Havering. Alcohol advice, signposting to resources, and advice on CVD risk. So I always give a printout of the, like the British Heart Federation or British Dietetic Association, those kind of things. And people do read about this because, they are scared, although they don't admit it. Most of them are scared, when they have a new diagnosis of high blood pressure. Because often in their minds is whether I'm going to have a heart attack or a stroke, and that's always in their minds. And that's the time we have to, find people and signpost them to appropriate resources, and the chances of, they involve themselves in the management are much higher. Next slide, please. So these are the 3 or 4 tiers for weight management. Yeah. So the tier 1, is like a, sorry about this, something coming in. Tier 1. So this is about like a brief management. They come to a GP, they come to a pharmacist, a teacher, in a gym, whoever, just a brief advice about weight management. And tier 2, that's what we do in our practices. You can refer for like a digital weight management and those kind of programs. Tier 3, as far as I'm aware, this is a multidisciplinary team, but as far as I'm aware, we haven't got it in BHR yet, but hopefully it will come, wherein the prescription of these medications to reduce the weight loss. Now, they fall under their remit, but hopefully at some point we'll have this tier 3, which benefits lots of our patients. And tier 4, of course, is bariatric surgery. Only few selected people will be eligible for this because they have to have their condition, either diabetes or hypertension, along with the high BMI. Next page, please. So this is the NHS Digital Weight Management Program. So this is an online access where we can make a referral. So if you look at the referral criteria, adults above the age of 18, BMI of 30 or more. Of course, for ethnic minorities, the BMI is less, and they should have either diagnosed with diabetes or hypertension or both. So we can refer through ERS in primary care. I've seen social prescribed, they can also refer in our surgeries. I've seen them people referring. Next slide, please. Right. Okay. So medical man. Sorry about the small print. So the medical manager. So look, this gentleman, he has. Yeah. Thank you. So this gentleman has got a first high blood pressure. Obviously, we don't treat based on one value, but obviously we have to confirm by doing further investigations. So it's either you can do a 7-day home blood pressure or a 24-hour blood pressure. And nowadays, with the pharmacists doing 24-hour blood pressure, much more easier, and they're much more quicker as well, rather than waiting for a organization in the cardiology to do it. So they're much more quicker, and they give an accurate indication of whether we need to treat them or not. And again, lots of my patients do buy the blood pressure machine at home. It's very easy for them to do. So normally, I advise them to do two blood pressure readings in the morning and 2 blood pressure readings in the evening. So sit on a sofa or a chair, relaxed, do a blood pressure first, repeat after a minute, the same way in the evening as well. So the first day we normally ignore them. So the remaining 6 days, you calculate, you make the average, and that gives a good indication of high blood, the blood pressures we need to treat or not. We do the blood test like kidney function, liver function, fast lipid profile, and HbA1c. I mean, this is at a baseline part of NHS health check to look for any end organ damage or they have diabetes or not. And then CVD risk Q3, unfortunately, it is not available in EMS. So we'll have to go separately in the online to calculate. It's easy, but however, it doesn't automatically calculate it. So we have to put all the values in to calculate the Q3 risk. So let's see, this patient's results come back as 155/95. So it is high, isn't it? So we do go to medical management because it is high. Apart from lifestyle, so as my colleagues talked about earlier, what treatment do you have? So if it is age below 55, you start with AC inhibitors. If it's Afro-Caribbeans, you start with calcium channel blockers. So this gentleman is 50, so or 55 about calcium channel blockers. And then if the Q3 risk is 10% or above, you start on atorvastatin for primary prevention. And usually I do ECG because at the time of diagnosis of high blood pressure, normally do a ECG for make sure the cardiac there's no cardiac complication, and also urine dip to look for any end organ damage in the renal system as well. Thank you. Next slide, please. So this gentleman, Peter is a Caucasian. So we start with Ramipril, 2.5 milligram. Check renal. So every time you start off AC inhibitors, because they have the potential to cause renal damage or to repeat renal function in 1 to 2 weeks. Monitor the blood pressure, titrate the dose. I mean, I'm sure all of you use a QRX or any form of text to communicate with the patient because they can send the blood pressure reading through. They don't need to come in person. They can send the reading, which is much more easier for all of us. Then the when the stable patient can self-monitor as well. Okay, are you okay with the first case? So there's somebody raising the question, like if they can't go for a 24-hour monitor, or if they can't do the home blood pressure monitor. Yes, of course, we can do the clinic blood pressure as well. And some surgeries do have like a pod, like a BP pod. The patient themselves can come and do it and leave the readings for us, and that can also be useful. They come in for, although we do 7-day blood pressure, but you can do like a 5-day blood pressure as well. So that can be useful. Okay, and then okay, that's fine. Can we? The last part, all patients with high blood pressure, they need to have annual review with the bloods, and also they need to check their blood pressure. Obviously, most patients do check at home, and obviously if there is a change, then normally they contact us. Thank you. Shall we go for the next patient? Omna. So this is a 32-year-old lady who is postnatal. Got a 6-month-old baby, and she came to the surgery with pressure-like headaches for 1 month. So she never smoked, no alcohol. Her BMI is 29. Blood pressure is borderline high. No abnormalities on any other on examination. So the question we have is, any other relevant history to us? She's a young mother, and also her blood pressure is high. She got some pressure-like headaches. Next slide, please. Of course, she's 32. She got a young baby. The blood pressure can be high due to stress as well, because when there's lots of stress happening, then they can have, the blood pressure can be raised. So any stress, obviously, it's important to exclude postnatal depression. So what kind of support do they have? Do they have a health visitor to support them? And obviously, it's important to exclude depression. So there is an Edinburgh postnatal scoring system, the depression system. That's a very useful tool to detect postnatal depression. Of course, we need to find out, is he breastfeeding or bottle feeding? Because, if we are going to start medications, then obviously we have to, be mindful of whether she's breastfeeding or not. And of course, we talked about the lifestyle factors, and then if any families have high blood pressure or cardiovascular disease. Thank you. Next slide, please. Of course, we do the home blood pressure, 24-hour blood pressure, baseline bloods, because he's quite young. And if the blood, if we confirm that, her blood pressure is high, we refer to secondary care to exclude secondary hypertension, because at this age, we need to make sure that there's nothing else going on. So it could be renal, could be cardiac, or it could be endocrine. So these are the baseline investigations. We do ECG, ultrasound of the kidneys, urine dip for protein and blood. And the endocrine, there's a urine 24-hour catecholamines we do, but it's cumbersome to do it in primary care because they have to go and collect it from the hospital, to collecting a container, and then they have to take it back again. So normally the secondary care often does these kind of investigations. So what to choose medication, it depends on the outcome of investigations as well. And then, as my colleagues said earlier, there are certain medications to choose from when they are breastfeeding. And finally, in terms of future pregnancy, so you have to be mindful of whether what medication we are going to put them on, because some of them are contraindicated during pregnancy. So, basically, you have to plan them. If some of them are put on ACE inhibitors or ARB. So if their pregnancy has to be planned, so that these medications have to be weaned off before they're pregnant, so that it doesn't affect the baby. Thank you. Next slide, please. So this patient's 24 blood pressure came as 135/85. That's the exact borderline. So we did still, it is on the higher side. We did make a secondary care referral, lifestyle advice. So we did discuss about the medication, repeat in 3 months. If the still blood pressure is high, then we can talk about it. So if we are going to put them on ramipril, it will be renal function 2 weeks at titrated dose. Pregnancy planning, like there are alternative medication like labetalol. If in case they're planning to be pregnant, then we'll have to put them on these kind of medications and annual monitoring. Yeah? Thank you. Next slide, please. I think that's
Sorry, Jyoti, yes.
Sorry,
That's
this got.
Hello, everyone. Sorry, I just have to make sure we do a little bit of time for questions, I'm afraid, because we have to wrap up.
Okay, all done.
in
That's
about
fine. Yeah.
Thank you so much for all of your hard work, Jyoti and Dr. Sherb and Singh, and of course, Manpreet, Senior Pharmacist Manpreet. Could everyone please stay? Don't go just yet, for questions, but also I'm going to put in the Zoom chat right now a survey, just 3 questions. This one will take 20 seconds. It's even less. I've condensed the questions. It's multiple choice. If you fill in this survey, then you get a certificate. Thank you so much.
Yasmin, if everyone has questions, if they're happy to tell us now, that'd be great. Because I also have 3 mini cases otherwise, if nobody has questions. So the practical cases that we do here in the practice. So if anyone has questions, we can go through that. If nobody has any questions, I'll quickly go through the 3 mini cases. That is just after the thank you slide. So we'll wait and see if there's questions.
I have put up the survey, 20 seconds. We'll wait a little bit longer for the questions. If there are none, we'll go back to the slides.
So I think we've got 5 minutes till the end. So any questions at all, anybody? We're happy to take them. We've had a good few questions in the comments section where people have questioned about having raised clinic blood pressure readings. What would we do with raised clinic blood pressure readings? And would we still advise home blood pressure or ABPM? What would the team do? So,
you know what I'll do? I'll just quickly go through the mini. I'll just quickly go through the mini case one. So right at the end, Yasmin has one slide, and I'll just quickly cover them. But I put them in because I've dealt with these cases in the practice, and I thought it might be interesting for everyone to see what was done. So next slide, please. And again. Yeah, so I'll talk through it. I was going to be a multi, interactive, but we don't have time, so I'll be quite quick. So I had, so this is a patient that was 89 years old, was on losartan, amlodipine, arfosocin, bisoprolol, and metformin. He had hypertension, AF, diabetes, and also benign prostate hyperplasia. His blood pressure was constantly reaching around 180. We weren't achieving anything with any of these medication. It was happening through a 3-4 months period that we were trying to take through medication. He was referred to hypertension clinic as well. And one of the reasons I put this in, because he absolutely did not want to start any more medications. He didn't want to have any more added to him. And this would be a good patient to consider either doing combination medications on, or what I did was I took away his alpha-socin, which was used for benign prostate hyperplasia, and replaced it with doxazosin modified release. It's got more increased dosage, and it's got a bigger window to actually tackle hypertension. At the same time, it's helping with the alpha blocker for the benign prostate hyperplasia. Next, please. So this patient was an 84-year-old patient. They were on ramipril, lecardipine, doxazosin, bisoprolol, furosemide, and they had heart failure. They was having no active change in the blood pressure. It was constantly around 170, 180. They had episodes of lightheadedness at this point, and neurology was normal. Oral scope exam was normal. They were referred to hypertension clinic. So after some discussion, I made a plan with them and told them that we're going to actually have a target blood pressure for you at 160 over 90 at the moment, because you're having symptoms of dizziness. You've got high blood pressure. Let's try and achieve a lower rate and target for this. So if you click next, Yasmina. So these were the options that were coming up. So next, please, all the way. So the one I did for this patient is I made a plan with them to slowly take them off the antihypertensives, because they're on so many already and nothing's working. So I decided to take them one by one to take them off. I started with the lecardipine and removed that. I added on indapamide instead. And now I'm tapering off the doxazosin, because I'm trying to see which ones were recently put on, and I'm taking them off because they've achieved no effect. We're just increasing pill burden. The cumulative effect, what we think will happen when we have 3 or more, it's not working. And the patient's just going to develop side effects. And next one. This is the last one. It's something that's a bit interesting. Patient was booked in with me because of an echocardiogram, showed new AF, ejection fraction of 40%, heart failure signs, and also dilatation of the aorta. Not at dimensions requiring emergency care, no acute heart failure. One interesting thing about patients like this, you're going to get them on medications for blood thinners. You will get them on rate control. So bisoprolol would definitely be a medication you put them on. But for this patient in particular, I put them on losartan instead of ramipril, because losartan shows in patients that have got dilated aortas with hypertension and heart failure, losartan has a better prognostic effect than ramipril. The consensus trial was done showing ramipril was good for heart failure, but losartan is very good, especially if they've got elements of even slight dilatation. To prevent further dilatation, choose ARBs rather than ACE inhibitors. And I think I rushed it through, but if we had time, would have made it interactive.
And we will be having the slides and the talk on the website, so anybody who wants to go through can always reflect and go back to the resources. I'd like to thank everybody for attending today. If everyone can please do the feedback form, and if there are any questions or anything, please email Yasmina and she will forward it to us. We will be more than happy to answer any queries or anything.
Brilliant.
Thank you.